On behalf of ISEH, I welcome you all to the ISEH webinar series. Today's presentation is titled Sickle Cell Disease Hot Topic from Fundamentals to Emerging Treatment. It will be presented by our friend, colleague, and well-known in the field, Dr. Victoria Costa. Dr. Costa, as you can see here, she's a clinical transfusion medicine specialist, Assistant Medical Director of Blood Bank at NYU Langone, and Clinical Assistant Professor in the Department of Pathology at NYU School of Medicine. She is also Associate Program Director for the Residency Program and Medical Director of Clinical Laboratory at the Cancer Center. Prior to joining NYU, she completed her transfusion medicine fellowship at Johns Hopkins. She is passionate about education and quality improvement efforts. Victoria, floor is yours.
Thank you so much. Thank you for the kind introduction and for having me today. So my name is Victoria Costa. I'll be speaking about sickle cell disease from fundamentals to emerging treatments. I do not have any disclosures. And just an outline of our talk, we'll review the pathophysiology and clinical manifestations of sickle cell disease, discuss transfusion support and management, and discuss therapeutic options, including new emerging therapies. To start with pathophysiology and clinical manifestations, to introduce, so sickle shaped cells were first identified in 1910 by James Herrick, as you can see in the picture here, and were formally published in a medical journal at that time, and that was the first formal documentation of sickle cell anemia. Shortly thereafter, the genetics of sickle cell disease was determined. Sickle cell disease, or sickle cell anemia as we know it, is due to an abnormal hemoglobin, the major protein within red blood cells that carries oxygen. To discuss abnormal hemoglobin, it makes sense to review normal hemoglobin first. And so fetal hemoglobin consists of 2 alpha globin chains and 2 gamma globin chains, and then transitions into adult hemoglobin, which consists of 2 alpha globin chains and 2 beta globin chains. And BCL11A, as you can see at the bottom here, is a transcription factor that is involved in this transition, and it represses the expression of the gamma globin genes and leads to that transition from hemoglobin F to hemoglobin A. And hemoglobin S, which is the abnormal hemoglobin that is seen in sickle cell disease, results from a genetic mutation, which leads to a single amino acid substitution, where valine replaces glutamic acid, and this particularly affects the beta globin chain. You can see this mutation by itself in homozygous state, which is the homozygous sickle cell anemia hemoglobin SS, which is classically referred to, or you can see it alongside other mutations kind of spanning a spectrum of disease states. The pathophysiology, so normally red blood cells are quite flexible and elastic. The sickle cells are less flexible, and especially in low oxygen states, the hemoglobin S fibers kind of polymerize and block vessels. And this kind of vaso-occlusion leads to ischemia and pain. Additionally, the cells are a lot more fragile and undergo hemolysis. And overall, this vaso-occlusion and hemolysis leads to long-term organ damage. Along with the vaso-occlusion and hemolysis, there's a lot of oxidative stress and inflammation occurring. Because of that pathophysiology, clinical presentations include a variety of acute and chronic conditions. In the acute setting,
You are muted, Victoria. Yep.
Oh, you guys can hear me okay?
We're good now. We're good.
Okay. And other acute conditions can include stroke or silent brain injury. On the chronic end, many patients unfortunately experience chronic pain, as well as chronic kidney disease and other um, issues. Sickle cell disease is quite prevalent worldwide, and in the US, affects predominantly the Black and Hispanic populations. Um, Survival in sickle cell disease. So with advancements, there has been improvement in survival. However, despite that, survival still does lag behind, about 20 years or so behind those without sickle cell disease. And really truly does represent, a public health crisis sort of worldwide. These are the projected estimates of newborns with sickle cell disease by 2050. And so the numbers will just keep going up. Really does intersect with other aspects of one's life, is a chronic, kind of difficult disease, does predispose people to infections requiring additional vaccines, and especially in other parts of the world, at risk for malaria, pneumonia, HIV, and other things, can lead to poor development, things in children, and can affect you throughout your life, leading to mental health conditions, difficulties maintaining job, and financial hardships due to pain and hospitalizations and other things. Um, I love this. There is a site where you can find artwork by patients with sickle cell disease. And so this is someone with the disease kind of artistically representing their life experiencing it. To discuss the therapeutic options, mainstays of therapy for many years have included pain medication, transfusion support, and hydroxyurea. The purpose of transfusion is to increase the concentration of hemoglobin A. Apologies about that. So to increase the concentration of hemoglobin A red blood cells and to improve oxygen carrying capacity, blood flow, blood viscosity, and intravascular hemolysis. And with this increase in hemoglobin A, it should suppress endogenous erythropoiesis that would lead to the production of abnormal hemoglobin S. Transfusion support can occur via two mechanisms, via simple transfusion or red cell exchange. Simple transfusion can be 1 or 2 units based on lab values and clinical context, so can be for a variety of the acute and chronic conditions that I mentioned. With simple transfusion, the risks include volume and iron overload, as well as hyperviscosity. Red cell exchange is, hooking them up to a machine, removing their blood, separating it into its components, removing the red blood cells, and replacing with normal donor red blood cells. And so this can avoid some of the risks that simple transfusion poses. Both come with a risk of, with the normal transfusion risks, including transfusion-transmitted infections, transfusion reactions, and exposure to red blood cell antigens and subsequent alloimmunization. Indications for red cell exchange in particular include acute conditions and non-acute conditions, and then this is from the ASPA guidelines. Category 1 conditions, first line therapies are for acute stroke and stroke prophylaxis, and category 2 and 3, kind of second to third line, include acute chest syndrome, pregnancy, recurrent vaso-occlusive crisis, and preoperative management. Per the ASPA guidelines, the targets for red cell exchange include targeting an end hematocrit at the end of the exchange of 30 plus or minus 3%, and to stay underneath 33 to 36% to avoid risk of hyperviscosity, and to target a goal hemoglobin S beneath 60%. That's kind of the main standard. There might be some variability from institution to institution. And it is a balancing act. So with transfusion, there are benefits, but there are certainly risks, as I mentioned, alloimmunization, acute and delayed transfusion reactions, and iron overload. Particularly regarding alloimmunization, many patients will be frequently transfused without their life, exposing them to red blood cell antigens and putting them at risk or um, actual development of red blood cell antibodies. And two reasons to explain this is because the blood that they're receiving has different antigen um, expression than their own blood. There are differences in blood groups between donors of Caucasian origin, who constitutes most of our donor supply, and our population who's receiving the blood. The second reason is that many are receiving blood during these acute phases, and the inflammation status at the time of the transfusion kind of revs up their immune system. They're more likely to develop an antibody. There are many preventative measures in place within the blood banking community in collaboration with hematology. One is to communicate with other blood banks that have treated these patients to obtain antibody history from all prior hospitals so we can respect those antibodies and provide appropriately antigen negative blood, even if we have no evidence of a red blood cell antibody at our facility. Along with that, to obtain extended red blood cell antigen profiling by genotyping or serology. And again, this is to um, know if they are at risk of making so we can provide appropriately antigen negative blood. And based on the two of those, to provide the correct antigen negative phenotype matched blood. Two of the main kind of transfusion reactions and outcomes that I wanted to highlight that are most significant, especially in this population, are delayed hemolytic transfusion reaction, DHTR, and hyperhemolysis, HSS, and they're often kind of discussed together and sometimes are occurring concurrently or need to be distinguished from one another. So delayed hemolytic transfusion reaction is one of the delayed transfusion reactions with the development of hemolysis treated in 10 days after transfusion that occurs as an amnestic antibody response. So usually someone was exposed to this antigen a while ago, developed an antibody, and it fell beneath detectable levels, and they were re-exposed, and it comes back and causes this reaction. Clinically, will present with fever, falling hematocrit, positive DAT, and elevated within your antibody. And I've included the official criteria from the CDC hemovigilance criteria for this. Um, most most of the antibodies implicated are going to be KID, especially Duffy, MNS, or KEL. In the literature, there are thoughts that there's even antibody negative mediated cases as well, although that constitutes a minority of them. Is something to consider. The clinical picture doesn't necessarily fit. And then hyperhemolysis, um, we typically think of it in those with sickle cell disease, but you can see it in other settings, thalassemia and hemonc patients. Um, Unlike DHTR, this is really destruction of both the transfused red blood cells with the antigen of interest as well as the patient's own red blood cells. So almost kind of an autoimmune phenomenon there. There is a lot of overlap in the clinical symptoms and lab findings with DHTR, which is why it's very hard to usually distinguish. A couple of the unique features: anemia with a hemoglobin lower than pre-transfusion values and a rapid decline of the post-transfusion hemoglobin A level, can be reticulocytopenic and usually not antibody mediated in a negative DAT. The purpose of really differentiating them is for DHTR, you still can transfuse and give antigen negative. For hyperhemolysis, there's usually an avoidance of transfusion unless critical need. So while transfusion has been helpful and is the mainstay of therapy, there's been long interest in advancing therapy over the years. And so since its initial discovery in 1910, a lot of therapies have been explored. So hydroxyurea was approved in the 90s, and is still frequently used. Early around then, transplantation was also pursued. Um, and kind of in the past 10 years or so, additional options have come about and have ramped up, including gene therapy, and additional medications that have come out on the market. And all of the therapeutic options, target specific areas of the pathophysiology, that I mentioned in the beginning. So one is changing the genotype, two is targeting hemoglobin S polymerization, three is targeting vaso-occlusion, and four is targeting inflammation. And you can think of these as medical therapies or curative therapies. So the medical therapies include hydroxyurea, L-glutamine, oxalator, which had come out and now has been withdrawn, so is no longer an option, and crisazolimab. Curative therapies include hematopoietic stem cell transplantation and gene therapy and gene editing. So hydroxyurea came out in the 90s, and continues to be um, a well-known option for sickle cell patients. Its mechanism of action, it kind of works via different ways, but ultimately leads to an increase in hemoglobin F, which is protective, and prevents sickling. And this can really help people with vaso-occlusive crises. Unfortunately, it does have limitations, including adverse effects such as myelosuppression, falsely elevated creatinine in other labs, toxicities including GI, skin nail changes, leg ulcers, and importantly, in pregnancy, which is often an important consideration for patients, and long-term effects, including affecting fertility and increasing cancer risk. So the barriers are from kind of multiple angles. From the patient side, concerns of carcinogenicity and teratogenicity. From the clinician side, questions of safety and efficacy have arisen, um, and systemic issues, including drug access and health insurance coverage, as with any drug. Um, Withdrawn drugs, as I mentioned, voxelotor, that had come out in 2018, 2019, or in 2019, and was withdrawn last year in September 2024. It was kind of affecting oxygen affinity, but has been withdrawn due to increased vaso-occlusive crises and deaths, and reports of deaths in two clinical studies outside of the US. So it's no longer being used. And then crisazolimab, also known as Advoceo, has been withdrawn, and this targets P-selectin, so kind of endothelial adhesion molecules. This has been withdrawn in Europe and the UK following a study that showed no statistically significant difference between the drug and the placebo in reducing pain crisis or hospitalizations. So this was, I think, impactful to the community. Felt like, many steps forward and one step back. And how do you handle this? So some literature I read felt, the limited details on adverse events were provided, and there wasn't, an explanation of who really was at most at risk, and limited guidance about how to discontinue or taper the medication in individuals that were on it and now that needed to be addressed. Once you took them off it, there were limited treatment options and ultimately led to loss of trust by patients. Um, and then besides the medical therapies, deciding to consider curative therapy is really a long and arduous evaluation, and multiple things to consider. The benefits of pursuing curative therapy, potential for significant reduction or elimination of complications of sickle cell disease, and potential for, improved life expectancy. The curative therapies do have their own risks, including graft versus host disease, or other toxicities associated with the conditioning regimens or chemo. And they tend to be much more costly as well. The common indications for curative therapy include recurrent vaso-occlusive pain episodes, more than two per year, life-threatening or recurrent acute chest syndrome, strokes, and the need for chronic blood transfusions. And these are just some of the common ones. It really is patient dependent, and there's some less common reasons. And so it's really a highly individualized process, and long discussions with the provider and the patient, and what they feel would be best for them based on their disease state. One of the curative options being hematopoietic stem cell transplantation was first discovered in 1984, and this was a patient who had sickle cell as well as AML, underwent stem cell transplant for her AML, and her sickle cell disease resolved. So it was first realized that it could be a potential curative option for the disease then, and since then is being continually explored. And we can think of it as autologous and allogeneic. Autologous is removing your own cells. So someone with sickle cell disease would donate their own cells. They would be modified by a manufacturer, and then prepared for infusion into that same patient. Allogeneic would be donated from somebody else. Looking specifically at allogeneic stem cell transplant, similarly is indicated for complications of sickle cell disease that are not well controlled with medical therapy, such as frequent pain, acute chest syndrome, stroke, or silent cerebral ischemia. Most of the data that we have really supports it in young population, so children or young adults, using ideally a matched related donor, so a sibling. They can have sickle trait or um, uh, have no sickle cell mutation, because it's really hard to find a matched related donor, and that's not possible for many individuals. Haploidentical related donor or matched unrelated donor or umbilical cord blood are also options and are being um, uh, more integrated into the protocols. Um, Allogeneic stem cell transplant in general has a good survival of 91 to 96%. It is more ideal in the young, and increasing age can lead to lower survival rates and higher toxicity. And the complications, due to the regimens involved, can lead to infertility and acute and chronic graft versus host disease. The main limiting factor is the availability of patients with matched siblings as donors. Autologous hematopoietic stem cell transplant offers a benefit over this, as you don't need someone to donate for you or have a matched sibling. You can donate your own cells, and you don't need to undergo the same immunosuppression. So there is not that same risk of graft versus host disease. So overcomes those two barriers. So you take your own cells, and then they're genetically modified, and that can occur via many mechanisms. The two main mechanisms I'm going to highlight here, and those are the methodologies that are used in the approved gene therapies that exist today. So one is through the use of lentiviral vectors that will insert genes, and so they can insert an anti-sickling globin. And then the second is through genome editing, so they can kind of go in and edit. Commonly will disrupt the BCL11A enhancer, that's usually involved in suppressing hemoglobin F, so they can go disrupt it and actually lead to the enhancement of hemoglobin F, which is protective against sickling. So the two FDA-approved gene therapies that we have use those mechanisms. They were approved in 2023, which is really big news. So one of them is known as Lyfgenia, developed by Bluebird Bio, and uses the gene addition mechanism that was on the left. And then Casgevy, developed by CRISPR and Vertex, uses the gene editing mechanism that was on the right. Both are for the treatment of individuals with sickle cell disease, ages 12 years and older, with recurrent vaso-occlusive events. So this has, really been sort of life-changing for patients who who have been cured of their disease, and offers a great strides forward in therapeutic options. Do not require finding a matched donor and avoids immune-related complications, and that's two benefits over hematopoietic stem cell transplantation. And as it is a fairly new therapeutic option, we do need long-term follow-up regarding many aspects of the therapy, especially regarding eligibility, who's really indicated for this, as you can see on the last slide. Um, Overall, kind of general safety, especially, and feasibility, sort of logistically access-wide to this for a larger group of patients. I thought this was a great article, kind of listing the unanswered questions that still remain. I think especially at the long term, kind of safety and efficacy in the middle. What are the long-term organ-specific effects? What happens to pain? Different things like that. And I think especially above, a lot of the data used for the approval of these drugs was in individuals up to 38. So what happens in individuals after 38? What if they have this level? What if they're doing well? These different clinical scenarios. So hopefully over time, we will have more data and information to better guide the management of these. The cost of therapy, I'd be remiss to discuss this without mentioning that the gene therapies are the most expensive of the therapeutic options, about 2 to 3 million, and the drugs, even themselves, prazilimab, oxalitor, all of those are a few $100,000, and these costs really just represent the cost of the drug, and don't encompass all of the other costs related to care. So as far as next steps, there are additional, although we have two gene therapy products approved, there are ongoing trials looking at other gene therapy trials. And I think there are efforts to address a lot of the unanswered questions. And we're always looking to refine, I think, the current therapeutic options. So as far as hematopoietic stem cell transplantation, as many don't have a matched donor, kind of looking at other avenues that would enable people to be transplanted, making regimens less toxic. And then, as we've had some newer drugs come out, kind of looking at other drugs that might be able to target the pathophysiology and be used as part of the regimen. So overall, it's been a long road in sickle cell disease care since the early 1900s. I think we've made significant progress, and there's still room for us to go, but we're doing great. So overall, today we talked about sickle cell disease, pathophysiology, clinical symptoms, and impact on patients' lives, and therapeutic options, including targets, transfusion support, and recent advances in therapy. So I'm happy to take any questions. Thank you again for having me and for your attention.
Victoria, thank you so much for your top-class presentation. As expected, we have received numerous positive comments. There are hundreds of online live audience actually, and we have several thoughtful questions. So unfortunately, we won't have enough time to address each individual question, but we'll do my best to summarize and incorporate few questions. Let me start here. So, your area of expertise, quality of life. So first question is, how to assess quality of life of sickle cell disease post-transplant?
Oh, that's a good question. So I'm sure that there's it's a multidisciplinary team that you can connect with, and everyone I think addresses different parts of your experience. But I think really, I think part of sickle cell care is that there's especially early on, there's mistrust from the community, right? So I think really engaging with people and asking how they're feeling, and there are usually questionnaires, formal questionnaires that can be used to target different aspects that apply to quality of life. So I think engaging those sorts of resources. And where I trained at Hopkins, they had psychologists and psychiatrists that were actively involved specific for the sickle cell community. So I think really advocating for those kinds of resources and incorporating them into your care can be really beneficial for everybody, actually.
Thank you so much. So next question is, there are multiple FDA-approved medical therapy, which you highlighted very nicely. What is your approach?
So yeah,
Medical therapy.
I'm on the blood banking side, so I'm not actually deciding the exact regimen. And here at NYU, um, I so a lot of our patients are go for their care here, and if they're going to be considered for transplant or gene therapy, I know several do go out to go over to MSK in Manhattan. I think there's really no right way. So much of it is really patient specific, and I think it's individualized. So you really need to kind of relay the benefits and the risks, and then ask people like what their thoughts are. I think they both have pros and cons, and it really depends on how well or not well a patient is doing, and then like what the ultimate benefit would be from them. But I think all of the options are safe, and I think the challenges are well recognized and being researched and further looked into.
The next question is, so maybe attendee joined late, but asking again, what is the difference between two types of gene therapy?
Yeah, so one is adding in a gene, and the other one is kind of going in and specifically editing the gene that is already there. I know it can be very confusing, and a lot of the terms are uh, synonymously used. Um, but yeah, that's kind of the main difference. So we have one therapy that adds in a gene, and we have another that is editing the gene.
So another question is, clinical question. Following stem cell transplant in sickle cell disease, few patients still keep visiting ER for pain uncontrolled. Label as an, ER physician always label as a pain crisis or VOD by ER physician. How common is pain crisis post-transplant and how to deal it effectively at out?
Yeah, that's difficult. So I haven't exactly encountered that myself. I unfortunately think that's one of the risks of any of the therapies, even with gene therapy, is that um, hopefully it will significantly um, improve your disease, but it might not. And I think sometimes that's hard to predict how people are going to respond and who is going to respond and to what extent they're going to respond. I would need to do more research on that.
A very nice comment. Thank you for your overview. Management of young female on hydroxyurea of childbearing
Yeah.
age.
Yeah. Yeah. So that's often the reason that many people want to come off of it, because of those risks. So I think that's fair. I would probably feel similarly. I think that's why there's been such a why there's a need and a kind of a push for these additional drugs to come out, as well as other therapeutic options. I think it's a little late, but I think we're getting there. But I agree with the concerns in that group.
And this patient is on Joanna's witness, no transfusion.
No transfusions. Yeah, yeah, yeah. So I mean, I think there's a lot of options. PBM and bloodless medicine has really grown over the years. So there's actually a lot of options for those groups. And anemia optimization protocols with EPO and other things. But yeah, I see that that does kind of narrow down what your options would be.
There are multiple questions about transplant versus gene therapy. What is your preference,
That's a good question. So I haven't had to choose for a patient myself because of my role. Um, I really find the technology with gene therapy really interesting and cutting edge, and it's very similar to CAR T cell therapy. And so I think we're going to continue to refine it, and it's really going to be, kind of like life changing for people. So that's my preference. But they both have their pros and cons, I think. So
Victoria, we have so many good, nice comments, but thank you again for disseminating the knowledge to help our patient.
Yeah, my
I
pleasure.
wanted,
Thank you so much for having me. Great to meet all of you.
I wanted to thank all our live audience for joining the webinar. And for those not able to join, recording will be available in next few days on ISCH website. This is in line with our mission of hematology without borders. Anyone can view all past recording anywhere in the world, anytime. Again, Victoria, thank you, and thank you all again.